Hello, everyone. Healthcare continues to make strides in innovation. However, most of these innovations are still very expensive. So, billions in India are one critical and chronic illness away from poverty. Even those who get covered deal with many long-term hidden costs, direct and indirect. And persons with kidney disease also fall into this category of, struggling with direct and indirect costs. Today, we will delve into this topic a little bit to understand what kidney patients deal with and what are the optimal, you know, treatments required for them to have better quality of life and where the big gaps are. As part of this topic, Patients Engage and Kidney Warriors Foundation will talk about how to advocate for financial access for persons with kidney disease, along with some of our key panelists. Our panelists today are Dr. Sanjeev Gulati, very senior nephrologist, president of Indian Society of Nephrologists, Vasundhara Raghavan, CEO of Kidney Warriors Foundation, a pan-India organization of kidney patients, both CKD, chronic kidney disease, as well as kidney transplants. Um, we have Sirisha, a public health professional consultant, a Ford Foundation fellow from India, and over 2 decades of public health experience working in health financing innovations and health tech innovations. And I'm Aparna Mittal. I'm the CEO of Patients Engage, a platform that focuses on informing and empowering patients of chronic diseases for better health outcomes. And I'm the moderator for this session. So let us get started because we have a lot to cover. Let me stop for now. Dr. Gulati, if we can start with you, what does optimal treatment of a person with CKD typically include?
Okay, so first of all, just for the uninitiated, how do we define chronic kidney disease? How common is it? I'll start off with that.
Sure.
So chronic kidney disease is an irreversible worsening of kidney function, which is documented over a period of 3 months. So all kidney function may not be irreversible. There are some that we call acute kidney injury, which is treatable. But if over a period of 2 months, we see that the kidney function is not improving, it is suboptimal, then we call it chronic kidney disease. How common is it? I think it's becoming commoner. The initial studies, including ours, when I was in SGPGI, we found very low incidences. We did a study, we found that if you look at all patients coming to hospital, about 5% had chronic kidney disease. That was a hospital-based thing. Community estimates were close to 10%. This was in the 90s. Currently, there is an ongoing study by the Indian Society of Nephrology in collaboration with a pharma company, and this is a national survey. We are targeting close to 2 lakh individuals all over the country. Not only that, in tier 2, tier 3 cities, we have preliminary information of the first 1.5 lakhs, and we have involved about 1,400 general physicians. We have trained them to, in the first stage, how to evaluate or diagnose chronic kidney disease and then look at this. So then the second part was the implementation. So our initial figures are actually startling, and the first 1.5 lakh patients data shows that the prevalence of chronic kidney disease is now 30%.
Wow.
So if you are, let's say, what does it 30% mean? So if I'm staying, like, let's say in Delhi, around my area, if I collect 100 people, 30 of them have got some degree of chronic kidney disease. So that is, I think, people need to be aware of it. When I started training in chronic kidney disease, we always thought it's a very rare disease, somebody else's problem. I won't mind. Okay, to be fair, we did see these patients very occasionally. But if now, because of, various issues, and we know that the two commonest causes of chronic kidney disease are high blood pressure and diabetes in the other order, diabetes and high blood pressure. And India also becoming, now by 2024, we are going to become the diabetic capital of the world, and the rising prevalence of hypertension. These two factors are the reason why the incidence of chronic kidney disease has increased to 1.5 times. So that is for everyone to understand that it's a fairly common disease. In terms of the burden on the society and on healthcare system, It is chronic kidney disease, has a lot of comorbidities. It affects the heart, it affects the brain. So people have a lot of other issues, and that's why it is projected that by 2024 it's going to be the fifth leading cause of mortality. And also because of the lot of comorbidities it has, there are frequent hospitalizations and the expenditure increases.
Correct.
So now coming to what is the optimal treatment of chronic kidney disease. So it depends. Chronic kidney disease is divided into 5 stages. Based on the percentage of kidney function, we also look at protein levels. So stage 1 is kidney function more than 90%. Stage 2 is kidney function 60 to 90%. Stage 3 is 30 to 60% divided into 2A and B. And stage 4 is 15 to 30%. And stage 5 is 15% or less. Now, the treatment always also depends obviously on what is treatment, as well as the need for follow-up and investigation depends on the stage of chronic kidney disease. So let's say people who have got stage 1 or stage 2 chronic kidney disease. So we are happy seeing them. The guidelines suggest that even if you see these people once in 3 to 6 months, it is more than enough.
Right.
The moment you move on to stage 3 chronic kidney disease, your things start getting difficult because also there are a lot of other issues. I would say you have to individualize, but once in every 2 months, stage 4 definitely once a month, and stage 5 literally every 1 to 2 weeks or every week. And stage 5 is the time that we start. Stage 4 is the time that we start advocating treatment options in terms of dialysis and kidney transplant.
Right.
Chronic kidney disease is a progressive disease. I think this is one thing that everyone needs to understand. People talk that they come to us saying that, oh, my kidney function is not improved. I tell them all we can do as of current date, the treatment options available are slowing the progression of kidney disease. And there definitely over the last decade, there has been tremendous advancement. We have newer agents coming in, so we can, slow down the progression. But with this, any new drug, you do understand comes at a cost. So that's why the costs of treatment of early stages of chronic kidney disease have increased, and outcomes have also increased. Let me say that. Yes, if I look back at my practice, when I started my career in nephrology, the costs of treatment, because we hardly had any agent available, we just had the ACE inhibitors, the Ramipril or Enalapril, and they used to cost a few, months treatment was a few hundred rupees. But today, I mean, especially over the last few years, there have been tremendous advancements. So besides these ACE inhibitors or angiotensin receptor blockers, we have the newer drugs called SGLT2 inhibitors. These are drugs we started by using in diabetic patients, but their use has been extended to non-diabetic patients. And then we have also Finerenone, which is a newer agent. All these tend to reduce protein leakage in the urine. So typically a prescription of a CKD patient, average we end up writing about 5 to 7 drugs. And that is where, the costs of treating chronic kidney disease are increasing. Partly, I think another reason is that if you look into we had again the ISN registry data is there, people are still coming to us much late.
Stage.
Earlier studies showed they're coming to stage 4 and stage 5. Now perhaps stage 3, stage 4. Very, very few people are coming in stage 1 and stage 2, and that actually obviously adds to the cost of treatment. I'll share with you a survey that we did at Fortis Hospital soon after I had joined. So what we did was we got out the records of the preventive health checkups. So these people had already come and gone back. And why they were doing preventive health checkup? Predominantly because their employer either mandated it or they had a complimentary, health evaluation. So 774 patients over a period of 6 months records were screened. And what we found was that 9.7% of these patients, when we went through their records, actually had chronic kidney disease. So they had come back, they'd done a free some blood test and gone back, not even consulted a nephrologist, despite being in contact with the healthcare system.
Right.
And to be fair enough, our system is also not that efficient that you send an alert to the patient that look. So this was a time when we were doing the serum creatinines, and at that point of time, once we got this data, I was able to impress upon the our laboratory colleagues that look, just doing a serum creatinine, my doing a calculation is, it's very cumbersome and it's not enough for the patient. So
You need to flag
that's the
it.
time we moved on to an automated EGFR. So there is a number that the patient gets, and that obviously I see when they come in now and they say, "What is this number?" And I said, tell them, "Look, this number says 27." So they ask, "What does 27 mean?" I tell them 27 means you've got 27% kidney function, so you are in stage 4 chronic kidney disease. And
Right.
their response is, "I'm absolutely healthy." So this is a patient who's not on any medication coming
Right.
to me for the first time. So even now, I think a lot of awareness needs to be created for chronic kidney disease. But yes, because newer treatments are available, the cost of even a stage 1 to stage 4 chronic kidney disease is high. Stage 5, we already know that dialysis is fairly expensive. Transplant is there. Transplant costs a lot. Post-transplant, there is lifelong immunosuppression, which adds to the cost. So that's why
Right.
this is in a nutshell, as I can put it. If there are
Right.
any queries,
Right.
I'll be happy to take.
No, I think that you covered it very well. I guess what I'd also like to add, as you said, that there are also other comorbidities that the patient is going through. So if it's, if they've reached end-stage kidney disease due to diabetes, they also have a lot of the other diabetic complications, and therefore they have additional doctor visits that they're doing and additional medications that they're doing, taking as well. So all of this does add to the cost of, the costs that the family needs to incur. Shreesha, from your perspective in the work you do, what are the additional, information that you would like to share on the gaps in terms of financial access?
So I could talk from a more public health perspective. As we see that it's estimated by 2030, India will be the world's largest population of patients with diabetes, and chronic kidney condition in population-based studies is mostly caused by diabetic nephropathy. And because of the challenges in access to care, over 50% of the patients are seen in their advanced stages of chronic kidney condition. And you can say that 2.2 lakh new patients add up for end-stage renal disease every year, and which additionally accounts for 3.4 crore dialysis every year. So that's the high cost of dialysis care leads to financial catastrophe for practically all families with such patients. And the true burden of this end-stage renal disease in India is not known. This is some data which you get from the centers, dedicated care centers. And there is lack of universal access to renal replacement treatment because of the absence of a renal registry. We do have a chronic condition, chronic kidney disease registry, but not an end-stage renal disease registry. So that's another, because you cannot really account for the health outcomes here and track them or even understand the financial burden these patients have. Because if you have a registry, that also accounts for estimating some of these predictions in terms of what these registries can give in, not only look at outcomes, tracking their progression, and also how much is the burden of disease for them financially. And even today, over 90% of the patients who require the renal replacement therapy in India die because of inability to afford the care. And even in those who do not start renal replacement therapy, 60% stop because of financial reasons. So that's the data which is out there. And among patients who undergo kidney transplantation, unexpected complications have the potential to impose even more further financial hardship, because there's immense gap with the financial access to families and patients with kidney disease. And not only financial solutions are available, but ones which are available are not accessible to the most in need. So that kind of amplifies the problem even further. And I see that many of these solutions which are coming up with digital financial models with financial lending or 0% interest loans for patients, or savings for patients, even general public-private banks, public sector unit banks. They are not making that more of like a health savings account where you can pay for the interest of the premium of the coverage through the interest they earn on the money. So, for example, if there is a 1 lakh cover in a savings account and they earn an interest of like 3,000 to 4,000 over a year, if that can be used for the premium of that patient for like a cover of 5 lakhs or 1 lakh or 2 lakhs, that not only helps them save money for any additional expenses, but also have a coverage for their insurance, where it doesn't really pinch much in terms of paying separately for an insurance cover. But then you can at least keep aside certain money, which you are earning a small amount of interest, but that goes as a premium. So that kind of digital literacy, financial literacy is not much in the common public. I think the biggest awareness with financial access, even before that, is that there is lack of financial literacy. Financial access will happen once you know that how literate are you with the finances, and you can manage those for any kind of condition.
Vasundhara ji, I think you've got a couple of slides, so let me share that. And if you can talk about, what has been your experience when you've recently done a study of a sample of kidney patients.
It is like this for past 5 years since Kidney Warriors Foundation has been there. We've tried to understand the needs of patients and to address them. The physical challenges or the medical challenges they have is something that we can only counsel them and soften it with kind words. But finally, it's the financial needs that really can make a difference in their life. So that we have been struggling to find a way to reach that goal. And we found the option is only available through an insurance because medicine costs are all determined by so many levels of pricing. And it's very difficult to get the same amount of discount across the states or patients receiving their medicine at their doorstep, because sometimes they need to go to the hospitals to collect it or go to a government outlet where they can get it at a lower cost. So there are a lot of challenges. So we are looking at the insurance very keenly. And what we found is, of course, the age and gender part will be there, where the skew is more in favor of the men. And but we found that 57% of the people didn't have any insurance. But surprisingly, the out-of-pocket was like 79.6%. And then we had to question them that what is happening? Why is your insurance not working? So we got to know that the government yojanas and insurance does not cover many of these critical tests like TAC level tests, which is so important for the post-transplant people. And then the biopsies are another issue. Like some people pay for the biopsies, some insurance companies pay for the biopsies, but some do not pay. And for the government centers, the biopsies are not paid. And then there is a gap of for the transplantees, that is people who underwent a transplant under the government scheme, are receiving only the cost of the transplant that happens during the surgery. Whatever is the cost, that comes free. But they have to spend a lot of money on the initial test. And that is a lot of money, because 1.5 lakhs can become a little more. I've stated 1.5 lakhs as a minimum or an average cost, but it could go up depending on repeated tests that could happen and stuff like that. So finally, the whole thing is that patients are a little uneasy about the insurance schemes because there is a bottom line. They need to know what is the small print there. And these are the problems that they are facing on the tests, the laboratory tests and investigations. So when you go to the dialysis part, patients going to the hospitals, patients and the caregivers spending outside the caregivers traveling with them, and they are spending outside the dialysis center is not even considered as any cost. In the case of patients getting the facility under the government, they have to go very far to get the dialysis. And of course, since it's free, they don't mind doing that extra bit, but that is a reality. Peritoneal dialysis is free, but because of the hygiene factors, many people in the smaller, the rural area and the BPL categories do not go for the peritoneal dialysis. As far as the insurance is concerned for dialysis, I heard that for hemodialysis, it's available, but it's not there for hemodiafiltration, which is a better procedure, better dialysis according to them, since the molecules are better filtered. And for peritoneal dialysis, one needs to be hospitalized to get the claim, to register the claim. We find that Andhra Pradesh has been very kind and generous, and they're giving a pension to the BPL of rupees 9,000 for dialysis patients and rupees 5,000 for post-transplant, which is not there in many of the other states. Maybe Haryana had introduced one. I don't know how far it has been implemented. But we need to look at this across the country so that the BPL patients can at least get their free medicines on transplant and many other things that are there is still a gap. When we look at the transplant costs, the immunosuppressants are paid for 3 years at MRP, and the patients are saying, okay, can we get it at a special discounted rate so that we can get the same facility for the whole year? Because now with the amount of the slab that they get is rupees 50,000 for 6 months, and that gets used in 3 months because of the MRP rates. So these are the problems and issues that we have. And we just need this concern to be escalated to the authorities, to the government, to the insurance companies, because we feel that the middle class is always sidelined, and they don't seem to get any relief in any part of the system, the medical healthcare system.
Right.
So insurance could be a good way of opening that benefit for them, because ultimately it's with the life of a person on dialysis or transplant. It's not only the person who's affected, the family has spent a lot of money, made lots of sacrifice, sold their assets and properties to keep one member happy and surviving. So it's a lot of sacrifice, and maybe a benefit from the insurance, which means that there is a happy thought that, okay, I'm not spending too much, I'm getting some relief, I'm being recognized as an important person in the society. That really makes a lot of difference.
Right. Thank you, Asuraji. Dr. Gulati, we looked at some of this data, right? It talks of how tests are not covered, post-transplant medications are not covered, even different forms of dialysis coverage is not, there's no parity in that. So what is the impact on the health outcomes of a patient when optimal treatment is not covered by, and we also heard, I think, from a few patients where I think in certain states, they limit the dialysis to 8 a month as well. So, there are those aspects as well. So what is the impact on health outcomes of a patient when optimal treatment is not covered?
So I think this creates a situation of double whammy. One, the patients are coming to us late. Second, when they see that the costs are escalating, so they try to cut corners. They will not come for regular follow-up, they'll not do these investigations, and that adds to the poorer outcomes of chronic kidney disease, and also brings a bad name to the disease, but in the end, yes, since if there's no point in talking about treatment which a patient cannot afford. You may have the best of treatments available, but in the end, if the patient cannot afford, it's just the penetration is not there, the outcomes have to be poor.
True.
To add to this, we have been looking at the status of alternative therapy. So education is also equally important for these people. And over the last 6 months, I've just been looking at alternative therapies, and it's surprising that even in a city like Delhi, 40% of the patients who came to me before they opted for I would say a scientifically validated treatment, had spent lots of money on unscientific and unvalidated treatments. I think this is another aspect which we cannot push under the carpet. In the end, if the patients are, that's why if you see the motto for World Kidney Day this year was bridging the knowledge gap. So what we have debated is that a lot of treatments have become available over the last few years. But in the end, if this treatment is not being able to, be delivered to the patient, it's not there. And so creating greater awareness among the patients about the scientific validated therapies is also equally important. And at the same time, as we have been talking about insurance, so opting for insurance, we all know, at the end of the day, insurance companies are business houses, and a business house is there not there for charity. Let's be very clear about it. They are there to run a business. So that is why that the moment a patient is diagnosed with chronic kidney disease, most of them are excluded from health insurance.
Right.
Nobody is going to offer health insurance to a patient of chronic kidney disease. So we have to work with the companies, with the government, that the access to health insurance should be there. And at the same time, the people need to be aware that they need to opt for health insurance when they're healthy enough, so that it's easier for them to get the insurance at a very low cost. So tomorrow, if they require the services of health insurance, they are available.
Right.
And the other issue with the health insurance, I think, as was very aptly pointed out by Vasundhara ji, is that almost no insurance policy is covering outpatient treatment investigations, which most of your early stages of chronic kidney disease, would have.
Correct.
Even very important tests like biopsy is not covered by. So we have patients coming to me who are insured, and the moment we tell them about a biopsy, and the biopsy, I can tell you the cost for a biopsy in any corporate sector hospital, it's highly subsidized. So but still works out to be about 30,000-35,000, because it involves 1 day's admission, an ultrasound, a room charge, processing for the procedure part, and then processing the tissue that is taken. So if you see, it is a highly subsidized, and despite the fact that when we certify that this is a test which can only be done after admission, there is a refusal from the insurance companies saying that the tests are not covered in your insurance.
And even if they are hospitalized, it's not covered, is it?
No, they are denied, because they say that you are being admitted for a test, and somehow there is this clause there in most insurance policies that your test will not be covered. So this is another aspect. I think the data is excellent. I must compliment Vasundhara ji and the Kidney Warriors Foundation for collecting this data. I think what we need to do is now work on this data. First of all, try to put it in print. Anything that's there in print will be respected by the government, by the NGOs, by the insurance companies. So I think as the president of the Indian Society of Nephrology, this time we are planning a patient advocacy group. And I look forward to working closely with the Kidney Warriors Foundation to try to improve. This is a big gap. And I said that, as long we could be getting the best of the treatments available, and we could be telling that, look, this is how we can slow down kidney disease, and this is how the outcomes of transplant can be improved. But if this treatment is not translated into actual availability to the patient, if the penetrance is not there, then that treatment is useless.
Correct. Correct. No, I think that is really important. And, if with the support of the Indian Society of Nephrology, I'm sure we can even expand the number of respondents and reach a wider network as well. Vasundhara ji, in your experience, I know you've summarized the challenges of access, but what has been the experience of members when they are not able to cover all of the treatments and investigations that are needed? What is the effect of that on the patient and the family?
So, see, that's why we are always constantly taking up topics like biopsies and doing the genetic testing to make the patients understand why these are very important, critically important. To be not doing to avoid a biopsy because it's a cost, it is something like that. That doesn't work out at all. In Mumbai, there are these trust centers where you get biopsies done at a lower cost. So people go and get it done there. So that is how they try to manage. Many of them are also going to the KEM hospital, government hospitals, to get some, get under
Relief.
the
Right.
BPL government schemes so that these biopsies can happen. So actually, we are pushing them to go and get into the government schemes because there's no other option. Even for transplant, for everything, dialysis, all the costs are so high. So we just say, okay, you want money? Okay, now what you do is go and get yourself registered under the BPL category. It means a little work, but running around, but it will help you in the long run. So we keep pushing them that way. But for biopsies, these small trust centers which offer discounts, that works out for them. But this, I can't talk about the other states. You see, I don't know what's happening there.
Right. So we need to kind of collate more data from all the states as well, or at least a wider representation of states.
Just that people talk more in some states.
Mm.
Some cities, people are talking more. In some cities, if you go to the cultural things are there, when you go to some other state, some other city, the way the people behavior is very different. They don't want to talk about these things. So they're just very shut about it.
Mm.
You have to keep asking them these questions that what do you do without insurance? How do you manage? So things happen.
Right. Thank you. So I guess the last bit is, what is the way forward, right? What should we be doing? How can we advocate together? Who do we need to bring together to make these changes happen? Sirisha, I'll start with you.
Sure. So, in terms of what we can do is, I think we'll have to have a healthcare ecosystem approach here, wherein we not only look at the patient side, we need to also look at the challenges from the provider side and the health system as a whole. Because there are several aspects which we see that in the private sector, which comes with various instruments for patients, irrespective of what disease area they're working on. As a social responsibility of a citizen, or even to change the behavior towards health, is something which will happen over time. Or if there is an episode in the family or your extended family, you get to understand why is it important or why it means so much to me. But as a general public, what are the things the health system or the government is doing in terms of bringing awareness among people for their general well-being? There are certain aspects which they focus, which is more mandatory, but as NCDs are becoming more pressing need of the hour, I think as the government, they are doing their bit, but from the stakeholders' perspective of a patient group or the institutions or academic institutions, research institutions, they also have to put out these quantifiable numbers out there for making and magnifying and ensuring what is the real picture today. I think that role is to be there, because especially when people don't understand the intensity of a problem, it becomes very difficult to explain them unless you are in trouble. Then only it becomes like, okay, this is my world now and I don't know what to do about it. But from an outsider's perspective, if I know that my father has a CKD, or some extended family member, I know a bit about it, but it
Mm.
happens in the family, you know more about it. But shouldn't I know this about it, even not having been there? What are the best ways of putting that education out there, awareness about there? And I think patient groups can be a biggest channel here to do that job by collaborating with the private entities and the government to bring that awareness, because they know the real pain points, the story behind the patient. Are there communities of practice for kidney disease patients where they can share and talk about their day-to-day challenges? The families could interact, understanding what is the support system you have. What are, like Vasundhara ji was just telling about, I have this policy, do you want to look at it? And then it's kind of a word of mouth. Is
Mm.
there a formal platform where we can bring these CKD patients together and have like a common circle of learning and sharing? That needs to happen. And I think the objective has to be clear whether we want to bring this awareness through health literacy initiatives, or are we trying to make some changes in the health policy by engaging with them and shaping the policy, for bringing changes in the insurance scheme for NCDs through the
Mm.
government. And the third is the private sector. How can I engage with the private sector to tell them the severity of this problem and what are the main problem areas which a patient will face during this treatment or disease management?
Mm.
Digital lending and saving solutions have to come out. How do you interact? Because now it's more tech-enabled platform. Many of the people have smartphones and people have access to a lot of applications. Can we collaborate with a digital app company or a mobile application company who can work on devising an intervention which talks about CKD, creates that awareness around the problem, and also magnifies this with making more financially accountable in terms of, if I have stage 1, I will have to spend X amount of money in the next 5 years. If I have stage 2, this is what I need. So at least I'm prepared. I know that what I need to do in terms of saving that amount. And in terms of the stakeholders, I think the biggest responsibility as a citizen would be to more of putting out to these different channels: academia, research, government, private sector, and then the biggest one is the patient group, because they have the knowledge, they know the experience, the patient experiences with them. And if those are articulated well, I think we know what we exactly need in bringing affordable and accessible healthcare for them.
Right. Thank you. So let's look at we've talked of what is it, what are the various components of optimal treatment. We've talked of the gaps in financial access. We've talked of the impact on the health outcomes, not just on the patient, but also the family. So what is it that we can do together, to change the scenario, to advocate for greater financial access, both from insurers as well as maybe more relief or more coverage from the government, given the commitment towards universal health coverage, and this week is Universal Health Coverage Day as well. So what is it that, I know, Dr. Gulati, you said that you know ISN and Kidney Warriors Foundation can work together on this, and as patients engage, we are happy to support as well. What would you have in mind, and what can be done to move the needle on this? We'll start with you, Dr. Gulati.
So I think, as I said, we are a democratic country. Democracy is a government of the people, by the people, for the people.
Mm.
In the end, yeah, the advocacy needs to be there. The government has a lot on its plate. And I think there is no doubt that for the government, for a people, for a country with more than 800 billion people, the priority is primary health care. But India is making progress, the GDP is increasing, and there are various models. I'm aware that a lot of South American countries with similar or even lower GDPs, chronic kidney disease, there's a national program. So it is covered by the government because of the enormous impact it has on the productivity of the people of the country.
Hmm.
Chronic kidney disease is one disease where, if you transplant a dialysis patient, we are making him a useful and productive member of the society. From
Correct.
a person who's dependent, on government support, on family support, to a kidney transplant can completely transform this patient into a person who supports the family. We have several examples there, and I think this is what the government needs to realize. If I look at the government programs also, so far, even in Telangana, the focus has been a lot more on dialysis. And when I talk to my colleagues, there's a dialysis program. There is, I think, the Prime Minister's National Dialysis
Correct.
Program is there, but there is very little to support a kidney transplant.
Right.
And even in a lot of, we have the central government health scheme, which funds dialysis. So anything which comes free, when I talk to these patients who are on dialysis, a lot of them refuse to go in for transplant, predominantly because one, the dialysis is funded, so
Right.
they are going to get it for free. Well, they are getting suboptimal. That also, it is 8 dialysis per week. It's not 3 times per week, 8 dialysis per month. So it's not 12 per month. But at least they get coming into the hospital, and if there's a complication, they get admitted. It's all taken care of.
Right.
Unfortunately, for a kidney transplant, they will require a donor from the family, which requires, although the transplant is also, being supported, but the very fact that the dialysis is free, it becomes a default option.
Right.
So the government needs to be proactively thinking about the cost of that. Ultimately, somebody is paying for it, and the society ends up paying for it. So the priority for the government, for the society, has to be to push these patients to a kidney transplant. How do you go about it? I think we should define that, okay, this much amount of dialysis would be free, and by the end of this, we do expect that you should go in for a kidney transplant unless you are not fit for it. So if there is a caveat and there is a certificate from a doctor that you are unfit, you would be given free dialysis, but beyond that, no dialysis is going to be free. On the other hand, the money that is saved here should be utilized to fund lifelong immunosuppression, which again, as was brought out by the survey, is not being done at all.
Right.
But then, as I said, that the government is not aware, and you don't have nephrologists sitting in the health ministry. And even if we might go to them at the ISN, it may not make an impact, because they may say that you are trying to promote yourself or the society. We are a quote unquote they could say that is a so that's where the patient advocacy comes in. That's where there's a joint initiative with the ISN and the say Kidney Warriors Foundation, telling the government that this is how the economics works.
Right.
So,
Right.
so that's where I see, and as I said again, that I look forward to working together. The numbers are important. It is a team effort always. It's a team that wins, not a person. The idea may be there, but unless and until we get together and work collectively, we won't achieve our goal. Because the task at hand is very big. And that's why we need a lot more people, a lot more ideas as to how to go about it. Obviously, these are two, we need some public health experts as to channelize it. But first and foremost, the literature, because when we go to the government, these surveys and all, unless and until they are published, so we have to publish them in scientific literature and tell them that, look, this is Indian data, this is Western data, and this is how the government will save money actually. And this is one language I'm sure everyone understands.
Correct.
And this is that's the way forward as I see it.
Right. Thank you. Thank you, Dr. Gulati. Vasundhara ji, any thoughts from your side as to what Kidney Warriors Foundation would like to do, or what you envisage as the way forward?
Kidney Warriors Foundation is now going in for CSR help. So we've made a pilot model for insurance where we are asking for corporates to help and pitch in. If we do this as a model and present it to the government, then maybe the government can take it up and implement it on a larger scale, because we are taking a sample of 100 people. We can't afford to do more than that. But if that happens, then we have got something, a story to talk about. So maybe sometime in 2023, some news we can get on this. But I'm really keen on seeing this pilot go through, because otherwise I don't see, I see that this has to be a public-private partnership. Otherwise, it's going to be difficult. And in this project, we are going to get the patients to pay a premium and then take back some money. So the feeling that I have received rupees X amount and I paid an X amount, which is smaller than the bigger X amount, double X amount, is a very, very positive feeling for patients and their families.
Right.
Because they just feel they live without any dignity because they've just sold everything. And what they have is just a smile on their face as if to show that a world that they are happy. But I can really vouch that none of them are feeling very happy with the type of life that they are leading, and the families are all struggling. So I think that's my final take on this,
Right.
and we will take it forward.
Thank you. Thank you so much, Dr. Gulati and Vasundhara ji. I think I think, each of the panelists has spoken quite well, as, Sirisha talked of in her session. We definitely need more innovative and inclusive solutions. As Dr. Gulati said, that we need to find ways to create those models. As, Vasundhara ji said, they're trying out some pilot, but we also need to put together the models which will make it make it crystal clear on the options available and what what the government needs to prioritize as well. And we also need to make sure that whatever solutions we come up with treat the person, the patient, and the family with dignity, right? So universal healthcare is not just a demand, it's a right. And I think it's important to remember that the dignity of the person should never be compromised. So thank you so much, Vasundhara ji, for kind of initiating this project, and for we hope that we can make a difference to advocate for better financial access. And because ultimately financial access is not just about finances, it affects mental health, it affects not just that person, but the rest of the family. So, and we want everybody to feel productive, to feel a sense of belonging as well in our society. So thank you so much.
Yeah, thank you. And I must compliment Vasundhara ji and Kidney Warriors Foundation for, taking up this issue, which I'm sure is going to, in years to come, is going to be a landmark project. Look forward to working. Thank
Dr.
you.
Gulati, I'm really looking forward to working with you this year
Sure.
on patient advocacy at all levels, and maybe even to write that article that you just mentioned.
Oh, definitely. I think we should. That's the first priority, to get it in print so that we are able to interact with the policymakers there. Right? Okay.
Okay.
So much.
Thank you so
Bye-bye.
much. Let
All the
me
best for
stop
your
the
conference.
recording. Yep. Thanks.